Okay then. All right, you say, well, I can't take a Prill, Barb. I got a terrible cough. I just can't take a Prill. They just aren't doing much in terms of this cough. I can't sleep. Okay, then we're going to switch you to a sartan, or we're going to start you on a sartan first. We can. They show equal efficacy. So you might want a sartan because they do have less side effects. They do have less cough. They have less angioedema. So a lot of your diabetologists and your cardiologists are going straight to sartans and skipping the Prills. And as you'll see in one of the next slides, that they are certainly equal in terms of what they do. So, who are they? You know them as Low. I call them the Sartan sisters. Low, Val, Candy, Irby, Tell Me, Olmy, and Azel. These are all your Sartan sisters. And of course, we know them as Cozar, Diavand, Atacand, Avapro, Mycardis, Binocar, and Adarbi is our newest little sister. These, again, block the receptors for angiotensin II. They do not block ACE. And that's why you don't get the cough. When you block ACE is when the bradykinin goes up. When something goes down, bradykinin goes up. When you just block the receptors on the tissues, you don't get the cough. You also don't get the angioedema, very low risk of angioedema. Hence why people like these better. Are the sartans safe for patients with a history of angioedema from the Prills? I just mentioned that you don't get it as often. It's a 5 to 8% rate of cross-reactivity, which means it's a 92 to 95% not going to happen. So given this limited percentage, we certainly will switch them. If you have angioedema and we want to keep you on something that blocks angiotensin, we will switch you to a sartan. Very carefully. We don't just throw it at you and say, call me if you can't breathe. So we'll switch you cautiously. And then, of course, here's our new information. Gotta get my glasses here. Our newest information, y'all, from the American Society of Hypertension, just this spring, hot off the press. All ACEs are equal in lowering blood pressure. ACEs and ARBs are both relatively safe. ARBs with less angioedema and less cough. ARBs may be better after an MI, so that's something your cardiologist will certainly be looking at with this new research. Both of them protect you after strokes, so it can be either a Prill or an ARB after strokes. No evidence whatsoever to combine an ACE and an ARB at the same time. So you don't use a sartan and a Prill in the same person, because the blood pressure can go to 0 and stay there. Now, if a cardiologist does it, or a nephrologist trying to protect kidneys, that's a whole different story. They're going to be watching those patients like a hawk. But as a rule in general family practice, you do not use the two together. Okay? Okay, so that's some of the new stuff out. We got more new stuff coming out about the drugs for blood pressure. Are you using aliskiren at all? Tecturna? Anybody see this used? It's a direct renin inhibitor called a DRI. Is this on your handout? This slide? Okay. The DRIs, called direct renin inhibitors, generally are combined with another drug like an ARB. But they're not that popular. I haven't seen them used too much. Some people say they work pretty well with high blood pressure in patients that have chronic kidney disease. So I just don't see them used as much. And then I've talked already about aldactone, spironolactone, and pleuronone is a second-generation spironolactone called Inspra. It just costs about 200 times more. Okay, so be careful with these drugs. It's the potassium problem. That's what we're concerned about. When you add one of those drugs with an ACE inhibitor, potassium levels can go into the 6-7 range. Will that kill you? First thing you see is peak T waves, and then it goes zzz, and then you go. So you really have to be careful with potassium. Now the other thing, this new study came out with the American Hypertension Society said, let's stack diuretics, meaning if one's not doing the trick, let's add a second one. So stacking diuretics, spironolactone, potassium sparing, with chlorthalidone, which is thalatone. Remember I told you about that earlier. That one actually gets rid of potassium. So what can we do? Give the two together, get a great diuretic effect without problems with potassium. Same thing with adding furosemide to reduce the hyperkalemia. But when you add furosemide, you also have to watch out for low sodium low magnesium, low everything. Okay. So let's talk about those beta blockers. Anybody with the last name Olol, Alol, or Illol, that's a beta blocker. If you sound like you have a mouthful of marbles, you are a beta blocker. Atenolol. This is the biggest news. Knocked my socks off. Absolutely don't use it. Right. How popular was atenolol? Tenormin. Look what it does, you all. Very fascinating. It will lower your brachial pressure. So when you take the blood pressure in the arm, Tenormin looks like it has lowered blood pressure. But it raises blood pressure in your brain, your heart, and your kidneys, which means Tenormin is associated with increased risk of stroke and heart attacks. Wow. So when these new recommendations come out, you're going to be seeing a lot of people switched from that are on Tenormin, had been on Tenormin, they're going to be bringing them off of that drug. Slowly. You do not stop it cold turkey. You never stop a beta blocker cold turkey, ever.
Is there any research to say that Tenormin also is related to have to have a pacer in earlier?
You know, I don't know. I've not seen that with Tenormin and a pacer. Yeah, there might be out there but I haven't seen it. It doesn't mean that it's not out there. I just haven't read that. Okay, so I'll just tell you this. Tenormin is going to be, the people who make Tenormin are sobbing, crying in their beer right now. But Betoxolol, which is Curlone, Bisoprolol, which is Z-beta or Monocor, Carvedilol. I put Carvedilol in bold because this is called a beta blocker plus. It means it not only blocks the beta receptors, but it is also something else. And it is an alpha-1 blocker, which means it's a vasodilator as well as a beta blocker. The new study are touting the benefits of the beta blocker pluses. So to use those as a second-line therapy for hypertension is a good choice. Now, Carvedilol was first marketed and only approved to treat heart failure, to prevent the remodeling of the heart. So I want to get back to that later on, but suffice it to say, you all, it has now been approved to treat resistant hypertension as well, as an add-on. So we'll be seeing it used for high blood pressure. Okay, then we got Esmolol, Brevibloc. That's used in emergency rooms. Labetalol. The reason this one is still good is because it is one of the only drugs safe during pregnancy. There are very few drugs that are safe during pregnancy for blood pressure. This is one of them. Metoprolol, is this popular? You betcha. So we use metoprolol generally for heart failure patients. And nebivolol, bistolic. Bold, it's a beta blocker plus. It boosts nitric oxide. Nitric oxide is a potent vasodilator. Okay, propranolol was the first one out. Hit the market in 1968. Do you ever see it used anymore for cardiovascular effects? Any yeses in the room? No. It really is more used for things like anxiety, panic attacks. It's used to reduce pressure in the portal system in patients that have portal hypertension. You just don't see Inderol used for cardiovascular things today. And if you do, the doctor is driving a horse and buggy to work. So I'm going to give you some of the other indications for these drugs in a minute. Sotalol, which is beta-pace, of course, slow down the heart rate. Timolol, Blocadrin. So these are your beta blockers. So quickly, and I promise you briefly and painlessly, we're going to review the sympathetic nervous system. That's what these drugs do. They block the sympathetic nervous system. Fight-flight response, remember that? Receptors, neurotransmitters. We have beta receptors, alpha receptors. Neurotransmitters are called epinephrine, norepinephrine. You remember the fact that when we taught you about this, if you have, let's say you visit me in Chicago, you drive up on a Friday night and you're late because traffic is horrible. You get into Chicago at 3 o'clock in the morning. You take a wrong turn into a neighborhood you're not familiar with. You run out of gas, your transmission falls out of your car, and you have 4 flat tires. what's going to happen to you? You're going to die. But shortly before death, you're going to say, oh, look, honey, there's a whole gang coming to help. It's called the fight-flight response. And that could be any neighborhood in Chicago. Just happened to pick the wrong one. So what's going to happen? You're going to see a whole group coming at you with Uzis and AK-47s, and you're going to say, so your pupils are going to dilate, your heart rate's going to go up, your blood pressure's going to go up, your bronchioles are going to be sucking in air as fast as possible because they're going to have bronchodilation. The blood flow to your arms and legs is going to increase because you're going to do what? You're going to try to get out of there as fast as possible. The hair on your arms and neck is going to stand up. What's that going to do? Well, a million years ago, we were covered with dark, coarse hair, so when that stood up, it made you look bigger and more threatening. Today, the 2 hairs on your arm and the 3 on your neck is truly not going to scare any gang. Look at the hair on the arms of my legs. It's really standing up. All right, so, and then, of course, you're going to have the shakes. Now, what do your bowels want to do? But interestingly, something else was built into the system, and it was called your mother. And that's the frontal lobe. And she says to you, I don't care what, you do not go to the emergency room with dirty underwear. She slams your anal sphincter tight. So during the fight-flight response, you are running and holding your butt. So there's no diarrhea going on here. Anyway, so that's your fight-flight response. Very simple. So, of course, all this has to happen through a group of receptors called beta-1 receptors and beta-2 receptors. And the beta-1 receptors are found specifically on cardiac muscle. So when epinephrine interacts with them, what does your heart rate do? Goes up, strength of contraction goes up, and you're pumping like crazy and your heart rate is beating like crazy. So simple. So what do beta blockers do then? Boom. Stop or slow it down. They don't stop it. But they slow down the heart rate and slow down the strength of contraction. That's why we used to choose them for hypertension, right? Decrease the heart rate, decrease the strength of contraction, your blood pressure fell. But we don't do that anymore. Don't use them for high blood pressure, daily high blood pressure. All right, but the beta blockers that do this are called cardioselective. They only work where? On the heart receptors. Okay, so cardioselective beta blockers block the reduce the heart rate by about 10 to 15%. Blood pressure will fall. Workload of the heart decreases. Used to treat angina. Can we still use beta blockers for angina? Yeah, you all. If you have angina, your heart is working too hard. There's not enough oxygen, so we can slow down that workload. We certainly can also use calcium channel blockers for that. So beta blockers can be used for angina, supraventricular tachycardia, post-MI remodeling. So we still use them for other indications. Examples of cardioselective beta blockers are metoprolol, low pressure, or Toprol, XL. I had to teach nursing students one time, first year. Or undergraduate, I should say. They were like third year in a pharmacology class. Usually I teach graduate students or NP students. So this one time I had to teach undergraduate students. I didn't realize that I used to be an undergraduate student too and knew nothing. And one girl raised her hand. She said, what does the XL stand for? Does that mean extra large? I said, yes. It takes 3 student nurses to bring that pill into the room. Really? Uh-huh. Now you just instruct the patient to gnaw on it all day. Oh. Anyway, so the sad news about all these drugs, some of them are called SR for sustained release, CR for continuous release, XL for extended length. That's stupid. Why don't we get one specific designation? But we don't. HS can mean half strength or at night. Now that's a problem if you think about it. So we certainly have some things to clarify here. All right, Z-beta blocker is bisoprolol, nebivolol, bistolic. So these are all called cardioselective. Now your beta-2 receptors, you all, when they are stimulated, because a gang is coming after you in the south side of Chicago, they're going to cause the tremor. The They're going to open up your bronchiole so you can suck in air so you can run. They're going to open up the large arteries of your arms and legs. So this is called the beta 2 response. We have beta blockers that are called non-selective, which means they will block both beta 1s and beta 2s. Could this be a problem with certain patients? If you gave a non-selective beta blocker to an asthmatic or a COPDer, what would that do? Of course, if you gave a non-selective beta blocker to a patient with diabetes with peripheral arterial disease, what would that do? Hasten their amputation. So, in other words, you got to be smart when you're prescribing beta blockers. You just don't say, "Oh, that's an OLA, I'll give it to them." You got to figure out which ones are going to be best used for your patient population. Okay, so your non-selective beta blockers are Inderal. Inderal is completely non-selective. You would never use that for what group of patients? Diabetics with COPD. All right, Corguard, Timolol, Correg is non-selective, so you've got to be careful what you choose. This actual lecture on beta blockers, you all, in a nurse practitioner class would take about 3 days for you to understand the ins and outs of all the beta blockers, because there's just a lot to understand about these drugs. In addition to that, we want to know if it crosses the blood-brain barrier, which is called lipid-soluble, or if it can't get across, which is called water-soluble. Your blood-brain barrier is literally made with, I always compare it to Crisco. So you just got a big grease thing covering your brain. So to get a drug through that, you've got to make it lipid soluble. What does water do to Crisco? Boom, repels. You can't get anything that's water soluble through it. So any drugs that have to get into the brain have to be what? Lipid soluble. So you don't want it to get in the brain, you make it water soluble. You say, well, you know what? What difference does it make if a beta blocker goes into the brain? It's a big difference, you all. In the brain, what did I tell you about norepinephrine? It gives you the energy to get through your day. It gives you your zing for life. It makes you say, oh my God, it's Wednesday, July 16th, I am going to a pharmacology class. I can't wait. Anybody? So it's, yoo-hoo, up and out. That's norepinephrine. If you give a drug that blocks norepinephrine in the brain, what's it going to cause? Yeah, it's actually not depression. Thank you for answering that. It's actually going to cause anhedonia, which is a fancy way of saying the lack of interest in life. I'm just not interested in anything anymore. I used to love to play softball on Tuesday afternoon with all the Springfield Clinic. I used to love to go to Quilting Bees with all my friends on Monday nights. My mother plays bridge 3 days a week. She's 89 years old, you all. She's a master bridge player. She remembers every card. She's unbelievable. If she told me she'd never wanted to play bridge again, I would know there's something drastically wrong with her. That's what beta blockers do. That do what? That cross the blood-brain barrier. So it's really not depression, but it's the lack of energy. I don't want to get out of bed. We all feel that way sometimes. This is daily. The worst drug of all beta blockers for this is Inderal. People literally say, I would rather have a migraine headache than be on Inderal. I'd rather have a root canal than be on Inderal, is how bad they feel on this drug. Okay, so that's the point. The reason we used to use tenormin so much, because tenormin is the most water-soluble or the least lipid-soluble. So what didn't it cause? Brain problems. Wow. Now we're going to realize tenormin is causing more problems than we thought. Does this make sense? All right, so let's look at the functions of beta blockers then real quickly, and then you'll understand why we sometimes use them. They decrease palpitations during panic attacks. What is a panic attack? Y'all, it's something in the brain. Even though it's manifested as a tremor, palpitations. It's really a sympathetic reaction that has gone haywire. So, in order to stop the tremor and the heart palpitations, we can certainly give a beta blocker. But we also like to use Inderal because what does it also do to the brain? Calms it down. We don't use it every day, but during an acute panic attack, Inderal is quite effective. Now, if you have panic attacks every day, we're going to give you a drug that is going to keep your brain calm all the time. It's called Effexor. Seriously. But some people only have a panic attack once every 6 months. You don't need to be on Effexor every day for that. Effexor is a fabulous drug for uncontrolled generalized anxiety, which is similar to a panic attack. Okay, so Inderal slows down the heart rate, helps you to calm down. We actually see it helps patients with PTSD that sometimes go into sudden wildness. Okay, beta blockers decrease the heart rhythm and atrial fibrillation. Of course they do. We can use beta blockers for atrial fibrillation like beta pace, Breviblock. Now, essential tremors. What is an essential tremor? Anything that's called essential, we just essentially don't know. So, what we think it is an upticking of the sympathetic nervous system. Slight upticking, and that's what causes the tremor. And it's usually in the head, and it's usually gets worse when you reach for something. So as I'm going for my Diet Coke, my hand will start to shake. Or if I have it of the head, I'll be up here lecturing with my head. My grandmother had it. My father has it. Tends to be familial. You might see me in a few years. So, what we try to do with essential tremors, you all, is give a drug that crosses the blood-brain barrier to slow down the sympathetic system. We tend to use Inderal for that. So you might see people on a low dose of Inderal to stop the tremor. Now, some people will say what to us? I would rather have the tremor than how I feel on Inderal. I feel awful on this drug. I don't know, does anybody work with a neurologist here? Anybody in neurology? There's an old anticonvulsant that neurologists will choose for essential tremor before they'll do Inderal because of the side effects of Inderal. It's called myceline. Anybody remember that old drug? I used to be an old peds neurology nurse. They use it for tremor. Yeah. It's really the first-line therapy, but most people have never heard of it. Primidone is its other name, myceline. So you might see that one used for the tremor instead of the Inderal. If it's a neurologist, a lot of GPs don't know about this drug. What's the difference between essential tremor and a Parkinson's tremor? Parkinson's tremors are at rest. So a patient with Parkinson's disease, if you see them, they'll be standing in Kmart or Walmart like this. So their tremor is while they are looking at the shelf, and when they reach for the hamburger helper, what happens? It stops. So it's a resting tremor versus an essential tremor, which is fine when you're looking at hamburger helper, but when you reach for it, it gets worse. I always quiz my graduate students. Which one of those patients would you give a straight edge razor to shave? Parkinson's. Absolutely. They'll stand here like this with it. But as soon as they come up to shave, it stops. If you gave it to my father, he'd be holding it like this and come up and... So, if you understand the difference between the two tremors, you'll know who to give a straight edge razor to. Alrighty. What's situational anxiety? That's another one we can use Inderal for beautifully. This is an example, is some students are beautiful students, fabulous students, they know their stuff, but they can't take a test. Test anxiety. Open up the test, first question, have no clue, and they panic. It's basically a panic attack. 80 to 160 milligrams of Inderal 90 minutes before the test, they will calm down. Yep, that's all it takes. I still tell the student they have to study. Doesn't make them any smarter. It's not a smart pill. What is a smart pill? Is there any smart pills out there? Yeah. The drugs we use for ADHD, you give that drug before they go for their GREs or their SATs, they'll score 100 points higher. I know, you're not supposed to know this. The students are not supposed to know this either, but it does really boost their scores.
That's in your ordinary kid that doesn't normally take it.
Right. And the ordinary kids that don't normally take it for their ADHD, you give Strattera to a kid going in to take the SATs, boom. It makes them pay attention, right? You pay attention, you actually read the question. You read the question, you actually can get the answer right. So we really do see that they can really boost scores. Mm-hmm. Now that doesn't mean your kid should go steal something from a kid. All right, anyway, so situational anxiety, people who drive race cars tend to have tremors going around a 265 mile an hour racetrack that's in a circular. If you have a tremor doing that, you're in trouble. So race car drivers take Inderal before they race. Students take Inderal before they take tests. Symphony orchestra players take Inderal before they play because it stops the tremor. It stops the anxiety. You don't take it every day. It's just before the procedure. All right, decreased symptoms of PTSD. We certainly can see that Inderal crossing the blood-brain barrier will help stop the hallucinations and flashbacks. Decrease the heart rate in patients with, by the way, you psych nurses, there's other things that help to stabilize the brain in these patients. They're called mood stabilizers. Depakote is one of them. Lamictal is another one. So we also use some other drugs for our PTSD patients as well in terms of helping them calm those brains down. Decrease the heart rate in patients with Graves' disease. Decrease portal pressure in patients with cirrhosis and esophageal varices, so those things don't rupture. Decrease migraine headaches by 50% in 50% of the patients. We have no idea why they work or how they work, but they can work in patients. The problem is a lot of these patients say, I would rather have a migraine than how I feel on these drugs. And then last but not least, sometimes we will use preoperative beta blockers in non-cardiac surgery in cardiac patients to calm their heart. So it's really a lot of uses for beta blockers, but what's the one thing you don't see on here? Hypertension. Okay, so they've become obsolete for cardiovascular protection, day-to-day protection for patients that have cardiovascular disease, because look what happens, you all. Today we have PCI, percutaneous coronary interventions. We have statins to do what? Prevent the atherosclerosis. We have clopidogrel. We have aspirin. So years ago, beta blockers were the mainstay of therapy to help prevent heart disease as well. Just don't use them as much anymore. Alrighty. Adding beta blockers to current therapies does not improve outcomes. Wow. Big findings. Exception, beta blockers are still used for decreasing the remodeling of the heart in patients with systolic heart failure. So we still absolutely see these used for that. All right, beta blocker eye drops. Second-line therapy, lower intraocular pressure by 20 to 25% when once or twice daily dosing. They all have the same last names. Timolol is Timoptic. Levobunol and Cardiolol and Motipronol. These are all drugs for pressure, glaucoma. But they are highly lipid soluble and cross the blood-brain barrier. Could they possibly cause anhedonia? The answer is yes. Beta blocker eye drops can actually cause your older patients to have no energy and lower their heart rate. Oh my God, she's got AV block. No, she doesn't. She's on Timolol. Ask about eye drops. So what can you use instead? What you should have used in the first place. The first-line therapy are called your Oprosts, Bimatoprost, Lumigan, Latanoprost, Zolatin, Travoprost, Travatan. These are called prostaglandin analogs. They lower the pressure even better than beta blockers. Now, when they first started using Bimatoprost, people would come back saying, "Look at my eyelashes. They're so long and beautiful. What's that all about?" And they said, "I don't know." So they then started a company out of California called Allergan, which does Botox and a bunch of other stuff. They said, "Wow, let's do some studies seeing if this actual stuff is actually what causes the eyelashes to grow thick and long." Sure enough, you all, these drugs actually increase the length and the thickness of your eyelashes. Beautiful, like Miss Piggy. Now, here's the problem. There's always a problem. I mean, my eyelashes, you can't even see them. They're so short and stubby. But this, and it's a little like brush that you brush right on top of it. The problem is, if you have light-colored irises, this can actually change the color of your iris forever to a brown. Not that there's anything wrong with brown eyes. They're beautiful. But if you're known for your gorgeous Paul Newman or baby blue eyes, this can truly, irreversibly change the color of your eyes. So you have to think, do I truly want long lashes or do I want my blue eyes? Or your light green eyes or your gray eyes. If you have a light iris, it can change the color forever. Choice you have to make. Okay. It's called Latisse, for Lash and Matisse, the artist. That's how they came up with it. Matisse, the artist. Latisse.
Your glaucoma patients with the other will have change in eye color.
Oh, the glaucoma patients, well, absolutely, if you have them on this. Oh, not absolutely. It can happen. It doesn't always happen, but it can happen. I think I'd rather have brown eyes than glaucoma. I mean, that's not a huge trade-off for me. But if it's if they don't have glaucoma and they're 22 years old and they want long lashes, you got to think about whether or not you want to change the color of your eyes.
I happen to have like an 89-year-old that has the lymphedema, and she is just, we have to send her in for a trim on her eyelashes.
Yeah.
This is just so wasted on you guys. I can't even.
That's funny. Very funny. I remember when we had a drug for blood pressure years ago called minoxidil. Do you remember that? And we'd give it to young kids because we had a dialysis unit on our pediatric floor. And it made these kids so hairy, they looked like little apes. It was hysterical. I mean, not to them, but they'd come in and woo, and then we realized, and that's the stuff that's Propitia's now. It's that old minoxidil we spread it on their head and people grow hair. But they had hair all over the face, and down the arms, and down the legs. They were just covered with hair. It was unbelievable. So, okay then.